and welcome to this afternoon session in room 4 on innovations in thoracic surgery. I'm Richard Milton, one of the surgeons in Leeds, and it gives me pleasure to introduce our first speaker, Relitza Baranowski from Barts, who is going to talk to us about navigational bronchoscopy. Carry on, Relitza.
Dear Chairman, dear colleagues, thank you for the opportunity to present today our experience on navigational bronchoscopy with correction of CT to body diversions. My name is Relitza Baranowski, and I'm a local thoracic consultant at Barts Thorax Center at St. Bartholomew Hospital in London, UK. Electromagnetic navigational bronchoscopy is a safer way to biopsy lung lesions with a low pneumothorax rate. The diagnostic yield reported in the literature is approximately 70%. Inaccuracy is partially due to CT to body diversions, defined as a discrepancy between the pre-procedural CT and the lung anatomy during the procedure itself, as well as loss of guidance during biopsy. We report the first experience of Illumicide, which addresses these shortcomings, and I'll present our 1-year follow-up data that is different from the submitted abstract. A short summary of the procedure itself. We start to navigate to the lesion as a standard navigational bronchoscopy. After that, we are doing a short C-arm sweep, like a mini CT called fluoroscopic tomosynthesis. That will put the lesion into focus and also blur the rest around it. And we can see, of this way, we can see even lesions that are not visible on fluoroscopy. And once we've identified the lesion, we can tell the computer where the lesion is now and mark it and also correct our position. The tomosynthesis is a very powerful tool, even in small nodules, like in this case, tiny nodule low in the lung, close to the diaphragm. And we can see it quite nicely, as well as the catheter position. In this scenario, we navigate to this position, and after the correction, we didn't think that we are at the nodule, but actually we are ready for biopsies after the correction. Of course, the opposite scenario is possible. We think that we're already in good position for biopsies, but after correction, we're actually not at the lesion and we need to again readjust. Another benefit of Illumicide is the sensor itself, that it's into the extended working channel. And even if we remove the locatable guide, we can still see where we are. And that allows us this view. At this image, we slightly pass the lesion, but we can readjust it. And the sensor allows us to readjust the position and also to not miss the lesion. We perform a prospective historical comparative study, Illumicide versus System 7 Super Dimension. All the patients and all the procedures were performed in January and February 2020. 27 patients for 28 biopsies were performed, and we compared to a historical cohort of 60 patients in 2018 before and after introduction of Conbeam CT, and also we've analyzed our 1-year follow-up data. 15 patients underwent 14 biopsies and 3 fiducial placement and 1 dye marking in the Illumicide without Conbeam group. Mean lesion size was 21 millimeter and mean procedure time was 41 minutes. 6.6% of the lesion could not be navigated to, and 64% had a malignant diagnosis. 12 patients underwent 14 biopsies with Illumicide and Conbeam CT. 4 patients had also staging EBUS. Mean lesion size was 25 millimeter. All lesions were reached, and our diagnostic yield at 1 year follow-up was 92%, 13 true positive and true negative. There were no complications and no pneumothoraces in both groups. And at this table, you could see our results, previous results with ENB alone, Illumicide, ENB with Conbeam, and Illumicide with Conbeam. As a conclusion, correction of CT2 body diversions with fluoroscopic tomosynthesis and continuous guidance improved accuracy of electromagnetic navigational bronchoscopy. Thank you very much for your attention.
Patients who have a negative biopsy with navigational bronchoscopy, whichever method that you use.
Thank you for the question. Actually, we are offering this procedure to very high-risk patients, and many of those are not even fit for surgery or any further invasive procedures. Do you mean like the lesions that we couldn't get to? How was their management?
Either you couldn't get to them, or there was a negative result on the histology or cytology.
If they're fit to for further operations, some of them underwent further lung resection, and of this way we actually could see our results at 1 year follow-up.
Okay.
We went back to all the. Sorry, we went back to our histology results from the surgery itself.
Okay, and it's interesting that you say that you're often doing this procedure in patients who are not fit for anything. This is probably not the forum to have that sort of discussion, but I just would question the need for doing a procedure where it's not going to change management. It seems as though, as far as I can tell, we have no other questions from the audience, unless any of my co-chairs have any questions. I'd like to thank you, Ilitsa, for that presentation.
Thank you.
Good afternoon. My name is Matthew Thomas. I'm one of the consultant thoracic surgeons from Glasgow. We have Lucas Kalinke. Good afternoon. We have Lucas Kalinke, who's a respiratory SPR from UCL, and he's going to talk to us about the EARL study. Over to you.
Hi everyone, my name's Lucas. I'm a clinical fellow working at UCH in London. Today I'm going to start by reviewing the histological stages prior to squamous cell lung cancer development. I'll describe the prevalence of high-grade pre-invasive disease at surgical resection margins. I'll review the treatment guidelines of pre-invasive disease with a focus on tissue-sparing therapies, give you an overview of the EARL trial, and some guidance on patient referral. So pre-invasive airway lesions progress through a series of morphological stages before cells invade the basement membrane. Severe dysplasia and carcinoma in situ are grouped together as high-grade lesions and mild and moderate as low-grade lesions. And these categories reflect the likelihood of the lesion progressing to cancer. It is high-grade lesions that are the focus of this trial. They are best detected under autofluorescence bronchoscopy. At UCH, we've used autofluorescence bronchoscopy for over 20 years and have shown that 50% of high-grade lesions become cancer within 2 years, whereas 30% will spontaneously regress. So what is the relevance to a thoracic surgical audience? Well, CIS can be found in up to 2.5% of all surgical resection margins. 85% of such lesions progress to cancer within a median interval of 37 months. And strikingly, 40% of patients who have CIS at their resection margin will have additional high-grade disease detected elsewhere in their bronchial tree. The guidance on how best to treat these lesions has a poor evidence basis. Studies are small, with different endpoints, and there has never been a control arm. The most recent guideline advocates surgical management of high-grade lesions. But as I've shown you, not all lesions progress to cancer. Often large surgeries are needed due to the central location of lesions. Patients are highly comorbid that can preclude safe anesthesia, and metaquinous lesions can develop, those being those that occur at a later time point. And this highlights the need for tissue-sparing, less invasive strategy. Options are photodynamic therapy, argon plasma, cryotherapy, endoluminal brachytherapy, and electrocautery, which is safe, it's cheap, and has been shown to have a response rate of up to 97% in treating high-grade disease. So the design of the trial, it's a phase 3 multi-center 2-to-1 randomized control trial. Other centers, apart from ourselves at UCLH, are Royal Brompton, Papworth, Nottingham, Wythenshawe in Manchester, Glasgow, and the VU Medical Centre in Amsterdam, who first pioneered electrocautery in treating high-grade disease. Our hypothesis is that the rate of high-grade airway lesion progression to cancer will be lower when treated with electrocautery. And our primary endpoint is the time to progression of any index high-grade lesion in a patient to cancer within a 3-year follow-up. We're aiming to recruit 101 participants. So this schema just shows the different recruitment strategies. So patients can already be on an autofluorescence surveillance program. Pertinent to this audience, we're hoping to recruit patients who have high-grade disease found at the surgical resection margins. As I've said, this occurs in up to 2.5% of all cases. Patients can have abnormal sputum, have a normal CT, and patients can be referred in from centres outside the trial sites where high-grade disease has been detected on normal white light bronchoscopy. So this trial flowchart, I just want you to draw your attention to the fact that patients in the treatment arm can have 3 rounds of electrocautery treatment in total throughout the 3-year trial period. So that's 1 round every year. And I'd like to conclude by saying we'd be really grateful for you to refer patients with severe dysplasia or carcinoma in situ found at the resection margin to help us to recruit to this trial and answer the question of how best these lesions should be managed. Recruitment has been slow, perhaps legacy of less bronchoscopies being performed, the COVID pandemic, but also perhaps a changing incidence in squamous cell lung cancer. Please send any referrals to the PI, Ricky Thapra, whose email address is on the screen now. Thanks very much for listening.
Lucas, thank you for that presentation. Thank you for introducing the EARL trial to us. I have personally referred patients for the EARL trial here in Glasgow, so I know a bit about it. But could you tell us a bit? I mean, this is a hot topic, isn't it? Carcinoma in situ and how they and its management. Could you tell us what your exclusion criteria for the EARL trial is, what you're using at the minute, and in the cases that you have burnt away the tissue using electrocautery, what are your results like? That's the first question. And the second bit is, once you've done the electrocautery, when would you perform a biopsy after the procedure to prove that it's been effective? Lucas, I can't hear you. You're on mute. And in the interim, whilst he unmutes, could the audience send as many questions on this hot topic as possible, please?
So thanks for the question, Matthew. So exclusion criteria, the main exclusion criteria is having active cancer at any site within any organ. In terms of any exclusion criteria to the actual lesion itself, the overriding one is that of a size. So any lesion that's greater than 3 centimeters is excluded from the trial. And that's purely down to the fact that Hans Daniels, who has sort of pioneered all this work, very occasionally you get sort of a carpet-like effect of CIS that spreads across the whole bronchus, and which is not amenable to endobronchial therapy. Other than that, the exclusion criteria is as for sort of most studies, we exclude patients who have severe renal or liver disease, and there are some exclusion criteria in terms of lung function, but you have to have an FEV1 of less than 25%, which is pretty severe. Your second question, what have our results been like? So the study opened just before COVID. We had 4 patients lined up. COVID hit, and since those patients have gone on to either regress back to a normal epithelium or progress to cancer, so are no longer eligible. But I can tell you that Hans Daniels in Amsterdam gets 5 to 10 referrals every year, and he said that the response rate is above 95% after the first endobronchial treatment, and any patient at any of the 5% that don't respond, he'll retreat 6 weeks later to get 100% response rate. It's a good question in terms of when do you biopsy. So in our study, we're taking biopsies 1 month after the treatment. Often it can be quite difficult for the pathologists to, because it's often the epithelium is just denuded or ulcerated, and it can be quite difficult to make an assessment straight away, and that's why we wait 1 month.
Thanks ever so much for that. That's really interesting. So my name's Adrian Marchbank. It's time to move on to the next one, I'm afraid. I'd like to introduce Adnan Bakir, who's a 4th-year medical student in Southampton. So well done, Adnan. And he's going to tell us about a prospective observational study to elucidate the role of intraoperative imaging in the management of pulmonary nodules.
Hello, everyone. Welcome to my presentation on a prospective observational study to elucidate the role of intraoperative imaging in the management of pulmonary nodules. My name is Adnan. I'm a medical student from the University of Southampton, and I'm delighted to have this opportunity to talk to you today. A bit of background. The Artis-Pheno cone beam computed tomography, or Artis-Pheno CBCT, is the image seen on the left. It's an innovative hybrid technology which can visualize pulmonary nodules in 3 dimensions. The aim of the Artis-Pheno CBCT is to improve the diagnostic yield and resection of pulmonary nodules. This can be done in 2 ways, through the image-guided video-assisted thoracoscopic surgery, IVAT, or a navigational bronchoscopy, in which the resection or biopsy of most pulmonary nodules, regardless of depth, size, or density, is successful. Our methods. We had a retrospective review of prospectively collected data, which was performed for all patients. That's referred through the lung multidisciplinary team for image-guided procedures. Patients underwent either an image-guided navigational bronchoscopy or an IVAT wedge resection. The information included the lesion size, depth, and locations, and the outcome included surgical complications, length of stay, and positive histology. All data was analyzed with SPSS statistics. The criteria for surgery, starting with the IVAT wedge resection. If the lesion was close to the surface of the lung with a high risk of lung injury and pneumothorax, or 2, if there was a high suspicion of malignancy and need for resection, or 3, if there was a need for a bigger sample for tissue diagnosis. For the navigational bronchoscopy, 1, if the patient was not fit for single lung ventilation and IVAT, or 2, if there was a lower level of suspicion of malignancy. I will now discuss the technique of the navigational bronchoscopy. Here we present a case on the left, on the image on the top left, in which you can see a suspicious pulmonary nodule and identified on a preoperative CT scan, which is also shown to be mildly PET avid. The patient is referred for an image-guided procedure. The time interval between the PET-CT scan and surgery is important in preventing any growth of suspected tumours. The suspicious nodule on either scan needs diagnostic confirmation by a biopsy before any therapeutic decisions can be made. Taking a biopsy from the nodule can be quite challenging, as the smaller the nodule, the greater the difficulty in performing the biopsy. This is where the artist pheno cone beam CT comes in. Once the intraoperative scan is complete, the surgeon can mark the nodule in red and the healthy tissue around it in blue in 3 different dimensions. This performs a 3D pathway to the nodule, in which the surgeon will use a navigational bronchoscopy to biopsy the lesion. The IVATS wedge resection is similar in its preoperative steps to the navigational bronchoscopy. However, the artist pheno cone beam CT can also use laser guidance to locate the lesion. Once it's located through the intraoperative CT scans, an interventional radiologist can mark the lesion. This allows the surgeons to form an incision and remove the lesion via an IVATS wedge resection. The results. There was 35 patients in total. The mean age for the IVATS was 59, whereas the mean age for the navigational bronchoscopy was at 66. The median length of stay for IVATS was 1.5 days, whereas with the navigational bronchoscopy, most of the patients were discharged on the same day. Regarding the positive histology, we had 100% positive histology in the IVATS cases, in which 6 came back malignant. And within the navigational bronchoscopy, out of the 24, 19 or 79.2% had positive histology, in which 5 came back malignant. Here we present further summarized data collected on both surgical procedures. Our discussion points. Firstly, the intraoperative imaging negates the need for transfer under anesthesia from the radiology department to theatre. It can all happen in a one-step hybrid approach. We understand our cohort was quite small, but however, the technique did demonstrate a low failure rate, a very low complication rate, and offered an acceptable positive histology rate. And 3, a nodule under a certain size depth for consistency can be difficult to sample. Here in Southampton, the bigger the nodule, the more superficial and the more solid it is and characteristic. It will undergo a normal bronchoscopy traditional biopsy. Whereas if it's smaller, deeper, and unsolid in its characteristics, it will go through the lung multidisciplinary team for an image-guided procedure. Thank you for listening, and I'm happy to answer any questions.
Thanks, that's really good and really, really interesting. And it's clearly great work going on there. I don't know if you can answer, but is there any role left for VATS for wedge and frozen section? Adnan, have you fallen off the screen? Oh, there you are. I think you're muted.
Hello?
Yeah.
Sorry about that. Sorry, could you just repeat your question again?
Yeah, so it was a really good presentation. Well done. Do you think there's any role left for the old-fashioned VATS for wedge and frozen section in theatre? Query proceed.
So the traditional way versus the image-guided VATS. I guess that kind of comes down all to the kind of characteristics of the nodule. The ones that are the niche group of patients that have small, deep, and kind of difficult to access nodules will benefit from the image-guided VATS. But for those who have kind of big, solid, superficial nodules, then I'm sure you're having the patient-centered approach, and they could just go through the kind of normal VATS procedure.
And I saw from your operating times that the length of time was about 90 minutes, about an hour and a half for this. Was that just the skin-to-skin time? Was that the entire time that the patient was in theatre?
I think that was the entire time the patient was in theatre. It was an hour and a half, yeah.
So it's pretty good then, isn't it? Excellent. We don't have any questions from the audience here. So 76% positive histology is better than the literature. How do you know with the benign lesions that you just hadn't missed the lesion?
How do you know I have missed the lesion? Yes, that's a very good question. You would presume that the 3D scan will pick up the lesion, but there's not a 100% kind of way to know. So there might be a case of false positives or false negatives where you haven't actually hit the lesion and you're actually hitting healthy lung tissue, in which it's going to come back as normal, but you might have missed a a case of cancer or another diagnosis.
So presumably you'd have to follow them up for a bit longer to see whether anything evolved.
Yes.
Do you have plans to do that?
It was part of my third year project, but I think they've picked up another third year medical student to carry out the work.
Oh, well done.
Thank you.
Good work.
Thank you.
Okay, so we're a little bit ahead of schedule, but only a minute or so. So next on the agenda is Maria Nizami. She's going to talk to us about subsiphoid non-intubated thymectomy, initial assessment of safety and efficacy.
Good afternoon. My name is Luke Williams, and I'm going to be discussing the Papworth experience of performing non-intubated subsiphoid VATS thymectomy, an initial assessment of safety and efficacy. To introduce this exciting topic, first we must ask why we would want to perform this procedure using this approach. And the answer is that the subsiphoid approach has been shown to be associated with less postoperative pain and a shorter length of postoperative stay than the traditional intercostal VATS approach in retrospective case series. Additionally, for thymectomy, the subsiphoid approach is particularly suitable because it provides the surgeon with a fantastic view of the anterior mediastinum and able to visualize both phrenic nerves simultaneously. Additionally, the non-intubated approach avoids the complications of endotracheal intubation, and in our patients with myasthenic symptoms for thymectomy, also avoids the potential complications of muscle relaxants and opioid-based anesthesia, which is traditionally used for endotracheal intubation. So to assess the safety and efficacy of this procedure, we analysed all patients who underwent the procedure since its introduction at Royal Papworth Hospital in October 2018 up until July 2020, and we retrospectively analysed the case notes to look for the adequacy of oncological resection, any postoperative complications, and postoperative length of stay. But before going on to discuss our results, I think it's important to highlight how we perform this procedure at our institution. Firstly, the patient is placed supine, sedation is administered, and a topical local anaesthetic spray applied to the pharynx before insertion of an eye gel. Superior rectus sheath block is performed using 1% lidocaine, a sterile field set up, and the incision is made inferior to the xiphoid process. The xiphisternum is dissected away from the rectus sheath, and a double hook sternal retractor, or sky hook, is applied to retract the lower sternum superiorly. The right pleural cavity is then entered, and the thoracoscope and instruments can be inserted with immediate visualization of the right phrenic nerve. The dissection takes place using a ligature device, and right phrenic nerve block can be used to minimize diaphragmatic movement during the procedure. Additionally, bilateral intercostal nerve blocks can be performed at the end of the procedure to prevent postoperative pain. Once the specimen has been removed and hemostasis has been achieved, the wound is closed in layers with a drain exiting through the wound. You can see the surgical approach to the procedure with the sky hook in these two pictures here. And in this picture, you can see on the left-hand side, the initial stages of the procedure with the right pleural cavity open and the right phrenic nerve visualized. And on the left-hand side, you can see the anterior mediastinum with the mass removed, and you can clearly see the brachiocephalic vein. On the left-hand side here, you see how we perform the phrenic nerve block. And on the right-hand side, you can see the surgical wound at the end of the procedure, in this case without a drain. And so to our results. Well, 15 patients underwent this procedure with a mean age of 56 and a roughly 50-50 gender split. 6 of our patients had myasthenic symptoms preoperatively, and 5 patients went on to have a histological diagnosis of thymoma. Crucially, R0 resection was achieved in all cases, showing that this is an effective oncological procedure. Our mean length of stay was 4.5 days, although 5 of our patients went home on day 1 post-operation, as this average is skewed by 1 patient who developed a post-operative chylothorax, which is a recognized complication of thymectomy. 2 of our patients had to be intubated during the operation, 1 of them for bleeding, which required a mini stenotomy for control. 2 patients developed post-operative AKI, and one patient developed persistent air leak requiring prolonged pleural drainage. So to conclude, non-intubated subsiphoid VATS thymectomy is technically feasible, it is an effective oncological approach, and it is safe. And we believe that it's particularly suitable for thymectomy as an approach because it affords the surgeon an excellent view of the anterior mediastinum with visualization of both phrenic nerves. And it also has added benefits for patients with myasthenia gravis. It may reduce postoperative length of stay and postoperative pain, although further prospective evaluation is being undertaken to determine this. Thank you for listening. Are there any questions?
Thanks. Very good presentation. Interesting. Can I ask one question, which is this now your routine approach for thymectomy in all patients? Or if it's not, what were your selection criteria for choosing this approach over the other conventional approaches? Hello, Luke. Have we lost Luke? Okay. Is anybody from Papworth able to answer? Okay. So there's another question for the audience as well, which is whether you use normal instruments or not. They look like super long instruments to me in the presentation that we saw. And I think the answer to another question from the audience about air leak and do you use a chest drain? But if there's nobody to answer them, I'm afraid we have to leave those unmet. Okay. So the next presentation is from Leeds. It's defining the role of navigational bronchoscopy service in the diagnosis of lung cancer within the NHS, and it's the Leeds experience. Can I just remind questions to go in to be submitted, ideally during the presentation, and also there's a chance to rate the presentation at the end. Possible to put the Leeds presentation up, please? Thank you.
Good afternoon, everybody. My name is Sula, and I will be presenting defining the role of a navigational bronchoscopy service in the diagnosis of lung cancer within the NHS, a single center experience. So what is navigational bronchoscopy? It is a relatively new technique that provides navigational assistance coupled with steering ability to locate and sample peripheral lung lesions. Its role has developed beyond its diagnosis to facilitate treatment and direct therapy. To perform a navigational bronchoscopy, the following components are required: the electromagnetic mat, which is placed under the patient, a location guide, a laptop computer with proprietary software for procedure planning, an imaging tower, a team of thoracic surgeons, anesthetists, and scrub nurses. The bronchoscopy, the navigational bronchoscopy procedure is performed in two phases: the planning phase and the navigational sampling phase. Over a period of 19 months, we performed 183 cases of navigational bronchoscopy. The mean age in our group was 75.3 years, with the youngest patient being 43-year-old and the eldest patient being 89-year-old. We abandoned 4 procedures due to technical and safety issues. The following graph illustrates the number of navigational bronchoscopy cases performed monthly in our hospital since the launch of the service in June 2017. I would like to draw your attention to the red bars on the right of this graph, which represent the number of cases performed during the COVID-19 pandemic era. Although the total monthly activity for our department was reduced by more than 50%, we performed in total 142 navigational bronchoscopy during this era. I would like to add that the following patients are not included on this presentation. 31 out of 183 patients had a prior attempt at CT-guided biopsy. The reason why we abandoned 4 cases was 1 had a big PA branch adhered to the lesion, 1 was due to an inability of the safely approach the target, and 2 cases due to technical issues. 34% of the time we used the fluoroscope to enhance the targeting lesions to improve the diagnosis. And we obtained a diagnosis in 62.5 cases, 40.2 had a confirmed malignancy, 22.3 cases had a lung cancer ruled out. In 13.4 cases, the results were inconclusive, whereas 5% of cases, the sample collected wasn't enough to yield the diagnosis. We had a false negative of a rate of 12.3, and this is largely because we accepted more challenging cases without endobronchial sign and with difficult morphology and location of the lesion. Our median target was 2. However, the target ranged between 1 and 7 targets. 30% of lesions that we biopsied were located in the left upper lobe, and this was closely followed by the right upper lobe, which there were 25.7 cases. We noticed that there was a difference in success rates between co-biopsies, needle aspiration, and brush cytology of an individual target lesion. Complication. We had a mortality of 0 for the 183 navigational bronchoscopy. 3.8% of patients developed a pneumothorax. 1 patient required a chest drain for 48 hours. We had no major bleeding. The length of stay in hospital was 0 days, with patients being discharged home on the same day as the procedure, apart from the patients with pneumothorax and those with no social support who had stayed overnight in hospital. So what happened following navigational bronchoscopy? 60 patients had a surgical resection. 41 patients received radiotherapy. Chemotherapy was given to 17 patients, and 3 patients were treated palliatively. 18 patients from outside of our area were lost for further follow-up. In conclusion, the navigational bronchoscopy is a safe method to obtain the tissue diagnosis in suspected lung cancer. Navigational bronchoscopy is evolving to be a major contender as a therapeutic modality in targeting lung lesions with radiotherapy, radiofrequency ablation, cryotherapy, or even radiotherapy. Our policy of only accepting cases are not amenable to or having had a failed CT biopsy lowered our eventual success rate. Our accuracy increased with the volume of cases undertaken after overcoming our individual learning curves. Thank you very much for listening. I'll take a few questions now.
Thanks. Yeah, that's very interesting indeed. It's good to see that the service is maturing. I have one question, which is that you stated that you're only offering EMB to patients where they've had a biopsy in CT that's been unsuccessful or been thought to be unfeasible. Are you still pursuing that strategy, or are you finding that EMB is now beginning to become a first choice in terms of getting tissue?
It all depends really on the MDTs where the patients are referred from. However, still, vast majority of the patients that we are getting are the ones that have had a previous CD-guided biopsy. Now, interestingly, from the MDTs that I have attended, the consensus is that, okay, this lesion is not amenable for CT guidance, or it would be better if we proceed with the navigational bronchoscopy, and those patients are sent directly to us from the MDT meetings.
Yeah. There's a comment from Kelvin Lau here. It says, very well done on excellent results, especially in the UK where EMB is used as a tertiary referral technique after CT, as you said. And he says that your results are as good as primary EMB in the US in the Navigate trial. So that really is praise indeed. He does have a question, though, which is, what was your median nodule size? Is the denominator nodule all patients? And given that you have up to 7 targets in a patient, what was the median size?
So the reason why we had many targets was, number one, we accepted more challenging cases, and number two, having more targets in different sizes of the nodule. Now, unfortunately, not all of our patients had a nodule size quantified per se. The median size, from what I could remember, for only about 45 patients had the nodule size quantified, and the median size was about 15 millimeters per nodule. But not out of, this was only 40 patients out of 183. And because we get the CT scans from out of area and we didn't get all the report. Additionally, not all 3 people were collecting data and were looking through the CT scan. Therefore, we could not find a set way of sort of measuring the lesions if they wasn't already reported.
I understand. Heterogeneity in the data, of course. Well, thank you very much indeed.
Thank you.
Okay, good afternoon for those who've just joined us. We've just had a presentation about the Leeds experience on the diagnostic uses of navigational bronchoscopy, and now we have a presentation from Hong Kong where we've got Miss Wing Yan Joyce Chan, who's going to talk to us about the therapeutic use of navigational bronchoscopy. Over to you.
What do I say? Good afternoon. I am Dr. Joyce Chen from Prince of Wales Hospital, Hong Kong. It is my pleasure to introduce to you our initial experience of electromagnetic navigation bronchoscopy, microwave ablation of lung nodules. These are our disclosures. So for lung nodule ablation, in terms of route of access, traditionally they were performed percutaneously. They were more readily available and widely researched, and were usually performed by interventional radiologists. However, more recently, transbronchial bronchoscopic ablation has been advocated with theoretically fewer pleural-based complications, including pneumothorax, bronchopleural fistula, and pleural effusion, and can be performed by surgeons or interventional pulmonologists. In terms of energy source, radiofrequency has had a long history. However, the latest evidence shows that microwave ablation actually produces larger and faster ablation zones, are less affected by the lung impedance, and have less heat sink effects. And therefore, we have combined the best of 2 worlds to produce a novel technique, the bronchoscopic microwave ablation. And together with adjuncts like electromagnetic navigation bronchoscopy, and performed in the hybrid operating room, which has real-time thoracoscopy and cone beam CT for guidance, we are able to gain access to lung nodules with fairly good accuracy. So how do we do it? The first step is to get the patient anesthetized and intubated, and then we perform ENB navigation towards the lung nodule. Next, we exchange the locatable guide to the microwave ablation catheter and confirm the catheter location by cone beam CT. As you can see here, the catheter punctures the lung nodule, which is outlined by the yellow tracings, and the green and red circles represent the predicted ablation zones. Next, we connect the system to an external console of the microwave, and then we just microwave it and press the button, usually for 10 minutes. And then afterwards, we assess the ablation success with cone beam CT. As you can see here, the surrounding ground glass opacity around the lung nodule represents the actual ablation zone, which corresponds quite accurately to the predicted ablation zones. So this is a retrospective single-center analysis, and we selected patients who were unfit for and refused surgical resection. Lesions were usually stage 1 primary lung cancers or isolated lung oligometastasis, or those nodules that are radiologically suspicious. Preferably, there should be a bronchus sign, meaning a bronchus directly leading to the nodule, but it is not absolutely necessary. And we prefer tumors with less than 3 cm size. We have so far performed microwave ablation for 41 nodules with a mean age of 68 years old. 68% were in the peripheral 1/3 of the lungs, and the lesion maximal diameter has a mean of 15.3 mm, ranging from 7 to 29 mm. So far, we have achieved 100% technical success rate, although 8 required double ablations. The minimal actual margin has a mean of 5.4 mm. The majority of patients have a speedy discharge. 3/4 were discharged on day 1, and 95% were discharged within 3 days. In terms of complications, 17% has mild pain, which does not require hospitalization. 9.8% had pneumothorax, and we have a fairly low rate of other complications. For the 16 nodules which have completed 1 year follow-up CT, there were no progressive disease. On the right-hand side, you can see a chart showing the percentage change in ablation zone volume with time. Basically, the ablation zone volume decreases rapidly in the first 6 to 9 months and then levels off. So in conclusion, by combining the bronchoscopic approach and microwave ablation, we are able to take advantage of the benefits of both techniques. ENB allows accurate navigation and localization within target lung nodules, especially in the hybrid operating room. We were able to produce 100% technical success rate and have a low complication rate. Therefore, we think that bronchoscopic microwave ablation is a promising novel technique for local treatment of early primary lung cancers or lung metastasis, especially in surgically unfit patients. Thank you very much, and I welcome any questions.
It's excellent to see the therapeutic uses of ENB. I have a question regarding the size of the ablation zone, and in keeping with the same question, I have a question from the audience, and that's basically, what are the rules with regards to the proximity to big vessels? Were stable or partial responders of big tumors close to big vessels? So why don't you answer that one first, and then I'll process the next question.
Thank you very much for your question. So the ablation zone depends on the energy that we use. So the maximum energy for the model that we have is 100 watts for 10 minutes, which produces an oval ablation zone of 35 mm times 41 mm. So taking into consideration at least 5 mm margin for any suspicious or confirmed tumors, then the maximum lesion size is actually 2.5 cm. And regarding your question about whether the stable or partial responders are actually those close to the big vessels, we do have a selection criteria that lesions with a border that is within 1 cm of very big vessels should not be included in our studies. And as for smaller blood vessels, like those 3 to 5 mm, in fact, we did an analysis that showed there's not too much heat sink effect. So in contrast with radiofrequency ablation, microwave ablation has been shown to have less heat sink effect, even in those with percutaneous ablation. So those with partial response, some of them are relatively larger. For example, those between 1.5 to 2.5 cm. So those definitely need to have interval CT scan every 3 to 6 months to look for any local recurrence.
Thank you. You have generated a lot of interest, a lot of questions here, but in the interest of time, I will have to move on. Thank you for your presentation to the SCTS. So,
okay. I hope you can hear me. It gives me great pleasure to invite Maria Nizami from Papworth, who is going to convince us that we should all be doing our lung resections by the subsiphoid approach in awake patients. So Maria, we look forward to hearing your presentation.
Everyone, my name is Maria Nizami, and I would like to thank the Society for this opportunity. I will present our department's experience in subsiphoid, non-intubated, opioid-free lung resections. Surgical approaches have evolved from multiportal thoracoscopy to uniportal thoracoscopy, and more recently to subsiphoid thoracoscopy. Subsiphoid uniportal video-assisted thoracoscopic surgery is a technically challenging operation that can help decrease the pain around the incision, as there is no risk of intercostal nerve injury, can provide anatomical benefits, utilizing a wider space, and is associated with early removal of the chest drain. It can also treat bilateral lesions through the same incision. Non-intubated approach has been increasingly used and has been associated with reduced post-operative respiratory complications, enhanced recovery by avoiding muscle relaxants and opioids, shorter anesthesia time, and overall shorter length of stay in the hospital. In our unit, we decided to merge the potential benefits from subsiphoid technique and spontaneous ventilation in order to assess the possibility of improvement in our patient's care. As you can see in the slides, the patient is positioned in a lateral decubitus position with a backward inclination of 30 degrees in order to optimize the exposure of the subsiphoid region, but also to reduce the interference of a beating heart. The incision is a 3 to 4 centimeter horizontal subsiphoid port in the infrasternal angle. In the process of creating the port, we cut the skin, divide the subcutaneous fascia and muscle layers to expose the xiphoid cartilage, which we remove as to establish a tunnel from the xiphoid to the pleura. A wound protector is inserted, and under thoracoscopic guidance, a suture is placed to retract and control the diaphragm. As the distance between the subsiphoid incision and the operative field is greater than the standard VATS, most of the instruments used are extended and curved-tipped. Now, regarding our methods, we looked at all non-intubated subsiphoid VATS lung resections performed at Royal Papua Hospital until May 2020. The notes were retrospectively analyzed to look for outcomes of surgical resection, resection margins, and post-operative complications, pain, and also hospital length of stay. 8 patients were included in the initial analysis, 2 with benign disease and 6 with malignant disease. 50% of them were male, and 50% of them were ex-smokers. Now, regarding our results, the median length of stay was 3.5 days, and prolonged air leak was reported from 2 patients with COPD. Our 30-day survival was 100%, and the surgical resection margins were R0, with no recurrence of disease. Regarding our anesthetic results, during the operation, we maintained the spontaneous breathing with LMA type iGel 4 or 5. We blocked the phrenic and sometimes the vagus nerve in order to control the cough and the paradoxical breathing, but also to increase the exposure of the hilum. Paravertebral and intercostal blocks were also utilized to maintain anesthesia. None of our patients developed respiratory failure or needed to have an ICU admission. We finally collected pain score data where 6 out of 8 patients reported no pain in the first month, and after 6 months, all 8 patients were pain-free. To conclude, our initial assessment of this novel approach suggests that it is technically feasible, provides adequate oncological resection, excellent surgical exposure, and it is safe. It is associated with similar complications to the traditional intercostal VATS approach, but it may result in a shorter length of stay, reduced post-operative pain, and early return of quality of life. However, we are aware of the limitations of our retrospective study and our small number of cases. Therefore, further prospective studies are needed to evaluate long-term results and to provide a further insight in our observations. Thank you very much.
I'm interested in how you selected your initial patients for this procedure. I can see the attraction in this approach for mediastinal disease. I'm less convinced about doing lung resections. So I'm also interested in how you actually started your program to begin with, if you had to get special approval to adopt a different approach. I know it's been done elsewhere in the world, but to adopt a different approach when we're all used to doing left or right-sided procedures. So first, if you tell me about how you select patients for this.
Yes, can you hear me well?
Yes, we can, thank you.
Hi, hello. First of all, I'd like to introduce Mr. Giuseppe Aresu. He's a lead consultant, thoracic consultant surgeon.
Hello, everybody.
Now, regarding your question about the patient selection, apparently for the patients with low BMI, less than 30 kilos per square meter, and then a less-sided operation is a bit more tricky or trickier. If there is a history of reoperation or adhesions, and also if there is a history of arrhythmias or cardiomegaly for the patients, then these are some negative criteria.
Yeah, in particular those patients, we selected right-sided operation because it's much easier for right-sided. Lower lobe as well is easier. And in terms of how we started, I used to work as a consultant in Italy. I did also a fellowship in Shanghai Pulmonary Hospital. So we introduced the Subsiphoid approach in a sort of gradual way for easier operation and then for more complex. In the meantime, we started here at Papua in 2015 the non-intubated program for lung resection. So we had a broad experience in uniportal VATS approach in patients that were not non-intubated. And then we started introducing Subsiphoid non-intubated technique for easier like biopsy of the pleura, wedge resection, and therefore, and then we step up and we start doing easy lung resection, anatomical lung resection in peripheral located tumor and early stage tumor. So that was the progression.
Okay, thank you. I think you've answered you've alluded to some of the other questions that have been posed on the website. Another question here, we've got time hopefully for the last question. You've mentioned that this approach is useful for bilateral lung resections. Is this something that you do, and would you be concerned about complications in this group?
So the thing is that it's something that we do if, for example, we have metastasectomy with 2 metastases in 2 different lungs, right and left lung. Of course, if we need to do a bilateral operation, we need also to take into account the timing, in the sense that if it's, for example, in case of metastasis, if the metastases are located at the level of the anterior segments, you can put the patient in a supine position and reach the 2 lung in a very easy way. Otherwise, in order to reach the mid or posterior part of the lung, you need to change position, so you need a lateral position, and therefore, in that case, you're gonna extend also the timing, the operation, and so it's something that you need to take into consideration when you are planning the operation. So it's something that when we have this kind of patients, we do also those considerations in terms of strategy.
All right. So we're just slightly over time, so I'd like to thank Maria and Giuseppe for that contribution.
Thank you very much.
You're very welcome.
Thank you. Next is Oliver Harrison. Oliver's an ST6 from Southampton. He's going to follow on from the previous presentation. He's going to talk about image-guided combined resection ablation in ICART, thoracic surgery, for the management of multiple pulmonary nodules. Oliver.
Good afternoon, ladies and gentlemen. My name's Oliver Harrison. I'm one of the thoracic surgery trainees in Southampton, and I'm very grateful to the Society for the opportunity to present this piece of work, which aimed to elucidate the feasibility of combining percutaneous ablation and VATS wedge resection under image guidance for the management of multiple pulmonary metastasis. Surgical treatment of multiple pulmonary metastasis centers around wedge resection and percutaneous ablation. Ablation is particularly effective for small, deep nodules. However, ablation of peripheral nodules can result in postoperative pain, pleural effusion, and pneumothorax. And of course, it doesn't provide tissue for histology. Wedge resection, on the other hand, does provide tissue for diagnosis. However, if multiple large wedge resections are required, this may ultimately reduce lung volumes. And of course, it may be unsafe in nodules that are particularly deep or close to hylar structures. So we developed a technique to combine percutaneous ablation and VATS wedge resection under image guidance to offer a one-stop personalized therapy that could be completely customized to the patient's disease. It involves a single anesthetic, and there's no need to transfer the patient from radiology to theatre. It provides tissue for diagnosis whilst respecting lung tissue conservation. So we retrospectively reviewed all patients undergoing this procedure between August 2018 and January 2020. And the procedures were performed in the hybrid operating suite at our institution using the Siemens Artisfino cone beam CT scanner, which you can see in the picture below. Data points included any history, prior history of malignancy, lesion size, depth and location, final histology, surgical complications, and length of stay. So here's a case example. A 40-year-old male patient with a previous diagnosis of rectal adenocarcinoma, which was just resected in 2018, presented on a surveillance CT scan with two new pulmonary nodules, one in the right lower lobe and one in the right middle lobe, in the left and right hand images below, respectively. So here you see the theatre set up, the patient's in the lateral position. An initial scan is performed to locate the lesion for ablation, which you can see there. Here's the ablation probe being inserted under laser guidance. And then a second scan is performed to confirm the correct position of the probe within the lesion, which you can see there. The microwave energy is then delivered, and a further scan is performed to locate the lesion for wedge resection, and the guide wire is inserted, as you can see there. You can see that despite the presence of a pneumothorax, the guide wire is still successfully located within the lesion. Uniportal VATS is then performed, and there's conventional wedge resection of the lesion with the wire still in situ, and then you can see the specimen being removed there with the wire in place. So over the study period, there were 4 patients that underwent this procedure, 3 men, 1 woman, and 5 procedures were performed in total. 1 patient underwent bilateral procedures in a staged fashion, and you can see the key study data in the table to the right-hand side there. There were 2 intraoperative pneumothorax, and 1 of these prevented successful ablation. 1 patient required a prolonged period of postoperative physiotherapy, and was ultimately discharged on postoperative day 6. All 5 histological specimens confirmed metastasis, and at a maximum follow-up of 24 months, there were no recurrence. So we demonstrate the first report of a technique combining percutaneous ablation and VATS wedge resection under image guidance for the management of multiple pulmonary metastasis, and it appears to be safe and effective from our limited early experience. It offers the combined benefits of the 2 approaches with histological diagnosis and tissue preservation, and can be performed in a single anaesthetic without the need to transfer the patient from radiology to theatre. The technique can be entirely personalised to the individual's disease, and with the introduction of lung cancer screening to the UK and the evolving role of ablation in stage 1 lung cancer, we anticipate the role of this procedure and the need for this procedure increasing in the near future. Thank you very much for listening, and I'd be happy to take any questions.
Thanks, Oliver. That's interesting. It's generated quite a few questions, actually. It's clearly it's pilot project. The numbers are relatively small. So Maria's asked is, so you had 8 patients in total. Oh, sorry, no. Sorry, excuse me. A question from Matthew. Would you ablate lungs where there was pre-existing pulmonary fibrosis?
Yeah, thanks for your question, Dr. Thomas. So not in this small series, they were relatively fit, young, healthy patients, albeit with metastatic lung mets. I don't know from my radiology consultant colleague's experience whether he's done any ablation in fibrosis. I don't think so, but I'll have to double check that.
Okay, so in the interest of timing, we're going to move on. I'm reminded to remind you to visit the exhibition because there are prizes to be won in the scavenger hunt, apparently. So The next presentation.
Yeah, I'm going to remind you not to go to the exhibition so that I've got a better chance of winning the prize. Anyway, now I'd like to introduce Marcus Taylor from Wythenshawe, who's going to talk to us about the Wythenshawe lung volume reduction and endobronchial valve program. So, Marcus, I hope you're there. We look forward to hearing your talk.
Good afternoon, everybody. My name is Farouk. I'm a junior clinical fellow of cardiothoracic surgery at Manchester University NHS Foundation Trust, based at Wythenshawe Hospital. And today I'll be presenting about our experience in lung volume reduction procedures. The title of our review was A Contemporary Experience of Surgical and Endobronchial Lung Volume Reduction Procedures. So to speak briefly about the main topic, emphysema is a pathological process associated with irreversible damage and dilatation to the airways, resulting in the formation of air spaces. We'll usually run into emphysema in the context of COPD, and when the disease has progressed enough, patients will be presenting with shortness of breath and impaired FEV1. The treatment options include inhalers, but will go up to lung volume reduction procedures in the form of surgical lung resections or endobronchial valve implantations. In the past, there has been some studies that conveyed evidence of symptomatic benefit after these procedures, but the evidence towards prognosis, morbidity, and mortality have not been very clear. So that is why the aim of our study is to review short and long-term outcomes in patients undergoing lung volume reduction procedures in our center. So this was a retrospective review in which we gathered data from August 2012 to December 2019. These data included the in-hospital mortality, the postoperative length of stay, and the overall survival. We've done our statistical analysis using SPSS. A total of 58 patients ended up having lung volume reduction procedures during this period. 26 of those had surgery, while the rest had an endobronchial valve implanted. About 2/3 of the surgical patients ended up having VATS rather than having a thoracotomy, and also 2/3 of the patient ended up having a sublobar resection rather than having a formal anatomical lobectomy. And in contrary to our usual lung resections for cancer, the patients in this study were relatively younger, with a mean age of about 60, and 2/3 of them were males. The mean number of valves implanted was 3 valves. In comparison, we've only had one case of postoperative mortality in the endobronchial valve group, and there was not a statistically significant difference. However, and as expected, the postoperative duration of stay was longer in the surgical group, with a median of 7 days versus 5 days for the endobronchial valve group, and this was statistically significant. 15% of our patients ended up having a prolonged air leak of more than 7 days, and we have followed up the patients for a total of 29 months, during which we have not found any statistically significant evidence towards a difference between the overall survival. So in conclusion, our study shows that favorable outcomes regarding morbidity and mortality can be achieved after lung volume reduction procedures. However, this is still a retrospective review, and among the drawbacks of retrospective studies is the quality of the data collected. And the postoperative FEV1 numerical data and the degree of shortness of breath and the actual disability, these have not been measured. And that is why we feel that it's absolutely necessary and imperative that we devise future cohort studies to further elaborate on these numbers and obtain stronger and more clear evidence. We also believe that careful patient selections via MDT is necessary and helpful towards reassuring the best possible results in terms of morbidity and mortality. So that will be all, and thank you all for listening, and we can be taking questions now. Thank you.
I think that generates lots of questions, actually. You did allude to the fact that all these patients should go through an MDT. Did you have an MDT in your setting? And following on from that, I want to know how you determined which of your patients underwent a thoracotomy as opposed to VATS, and how you determine the extent of resection? I hope that question came through okay. Did you hear me? Can anybody hear me?
So
Farouk,
Marcus is saying that he can't. He's running into an issue where he can't hear the speakers. Is it all right to use the chat function for questions, and I will then read them out? So, okay. So, has anybody else got any questions that which you can answer? And I'll start typing.
type quicker, Adrian. Need a secretary. Come on, SCTS, provide us with a secretary. I'd be interested, whilst Marcus or Farouk is responding, I wonder how many of my co-moderators do thoracotomy in LVRS, or do you do all VATS, or how many people will do a lobectomy?
VATS or robotic?
Robotic, yeah.
Exclusively VATS.
Yeah.
We have done lobectomies before as LVRS in patients with, but usually that's been for another indication, so they've either had a tumour or an abscess, and then we've done LVRS as lobectomy. Maria, I think you're muted. Okay, so maybe we could move on to the next presentation whilst we're waiting, and then we'll put the answers, Marcus, to the questions to Marcus in the chat.
Good idea.
Okay,
so we've heard about tubeless VATS and tubeless subsiphoid procedures, and now we have Professor He from Guangdong in China, who has come back to challenge us with tubeless robotic tracheal resection. So let's hear from him.
Ladies and gentlemen, I hope to share my experience of tubeless ROS tracheal reconstruction. I'm Dr. He, and this is my context. Our hospital is more than 100 years. Guangzhou near Hong Kong and Macau. That's our team. Our department every year with more than 5,000 case was operation, and also perform the tracheal and lung and heart and lung transplantation. Last year we had 88 case lung transplantation. And since 1996, there are more than 8,000 cases tubeless ROS. And also, our center is training center for the minimal invasive surgery. It's our team, the big team. And we view the tubeless ROS in our center. And from the 1996, when we began the needlescope ROS, and that time we like to use the intercostal nerve block to do the needlescope operation. From 2011, we began the non-invasive lobectomy. And from the 2014, we began the sleep lobectomy. And 2015, we began the tracheal reconstruction and the coronal reconstruction. The 2016, we used the new portal that was to finish the tracheal reconstruction. And this year, we begin the tubeless ROS tracheal and coronal resection. And how about intubated compared with the tubeless? We know that during the intubation will cause tracheal damage, like severe loss. And also, mechanical ventilation will induce the lung injury. And muscle relaxants will cause the cardiopulmonary injury, and also the joint tube will damage the nerve. And now, in some case, we not use the muscle relaxants again, and don't need the tracheal intubation, and also no joint tube, and no the urinary catheter. This is the video to show how we do the operation size, the anesthesia. So during the operation, we use the IV sedation combined with epidural block or intercostal nerve block, and maybe vertebral anesthesia and the vagus nerve block. What's the advantage from tubeless anesthesia? Will enhance the recovery after surgery and avoid the learner's effort of the muscle relaxants, and avoid the intubation-related trauma and reduce the cost. And how about the patient breathe during the tracheal and groin resection? The patient breathe from the operative port. So the patient, because the patient not use the muscle relaxants, the patient can breathe by himself. So we call spontaneous ventilation during surgery. And what's benefit from the tubeless? And from our tubeless operation with some analysis for the tubeless was where the mortality is lower, and also the complication is lower, and the safety. And the post-operative health score is also lower. So the tubeless, like the early stage lung cancer, is easy and cheaper. Traditional RAS tracheal reconstruction deploy how to maintain the good oxygenation state. Maybe the patient need repeat intubation during the operation. Maybe the patient need ECMO support to do operation. So we know ECMO, it will easy damage to the blood system and high cost. So during the operation, a transitional method is the intubation. So for the surgeon, we know if the tube is inside the trachea, for the surgeon, it's not easy for anastomosis. But during the operation, if no tube inside the trachea, for the surgeon, easy the landing suture. So for the surgeon, if no tube inside the trachea, it's not difficult again. Case one, we use the tubeless RAS tracheal reconstruction. The tumor locate the middle of the trachea. With bronchial Subsiphoid that the tumor locate in the middle of trachea. The patient have another birth scar, and during the beginning, and we use the fluorescence to evaluate the cutting edge. So use a robotic scissor at a different angle. They have the 7 different angles, so for the surgeon easy to control and also suture. And it's Moses, the trachea both side. So for the surgeon, no tube inside the bronchial and trachea for surgeon is more easy. After operation, 12 hours, the patient work is good. 3 days later, after operation, the X-ray is good and patient is comfortable, discharged 3 days later. The temperature, everything is good. So, tubeless RAS, the tracheal and coronary resection. We have the thoracic tracheal resection and reconstruction, and coronary resection and reconstruction, and secondary coronary resection and reconstruction. Now, so this video, like the patient, is a tracheal, left mid broncher, and right mid broncher. So we also use 3 polymer, and anastomosis, the left mid broncher, and trigger the first. This young lady, the coronary cancer, and upset the 2 cause of immunotherapy combined the chemotherapy first, 2 cause. And then when the tumor becomes smaller, we decide to do the tubeless RAS operation for her for 4 incisions. This patient will use the epidural combined with the IV sedation combined together. And also use the fluorescence to locate the edge of trachea. Also use the robotic arm, the scissors to cut the trachea. So these scissors are different angle for surgeon is easy to control. And there is a coronary. So we use the scissor to cut the right mid broncher. Almost the right mid broncher is cut off when near to see the middle broncher. This is the left mid broncher. First, we also use the 3 pointers and the Moses, the left mid broncher and trachea. Use the robotic and easy to use the left hand and the right hand combined together. This suture the left mid broncher and trachea and the right mid broncher to create the new liner. That's our operation room. Use the fancy machine. So during the operation, move the tube inside the trachea and cleaners for surgeon more easy for anastomosis. What's the advantage from the tubeless RAS? It's safe to complete the procedure. It simplifies the suture process. You don't need the ECMO. And enhance the recovery after surgery. And so many surgeons did our operation like medicine, Thymectomy, and we our center. Also, we have so many nasocolic, perhaps non-intubated thoracic surgery, and tubeless surgery. That's my some experience. Don't dot it out before you try it. And also, this speed will benefit from the surgeons and the anesthesiologists and surgical nurse and surgical team, and also we welcome all of you to visit us. Thank you.
Presentation. Thank you, Professor Hay. That was a fantastic presentation and very inspiring, as always. I'm lost for questions, to be honest, and I would invite questions from the audience. I do remember Professor Hay presenting on his experience of tubeless VATS cranial resection in 2018. This is a step ahead. I think we just have to go there and learn it and see it. I'm trying to look at the questions that could be there for Professor Hay here, but I don't have any.
There's a question from the audience. What's the mean time for the anesthesia and the surgery? So how long does it take? Is it a very long time? It looks pretty slick to me. Is Professor Hay there? No.
No.
Okay. Okay, so I suppose in the absence of any further question, how many ports? And then somebody's asked how to consent, and somebody else says, how do you remove the specimen? Do you have to extend the incision in one of the ports? I guess probably does, I suspect. All right, so that concludes this session on innovations in thoracic surgery. Thanks very much to everybody for attending. Thanks very much to my co-chairs for their help with all of this as well. And I will remind you once again, to go to the exhibition, but I will also tell you not to play the game so that Richard wins. Thank you very much indeed.
Take care.
Thank you lot. Great.
Thank you. Bye.